my pleasure to invite
Thank you.
Dr. Francesco Signorelli.
Hi, Naren. Hi, morning, everybody.
And Dr. Signorelli was in Lyon and now in Bari in Italy. We go back a long time, and he has been a regular speaker.
Right.
So look forward to your two talks. One is on Cavernoma, and
The first one is on Cavernomas.
and the other one is on intracerebral hematoma. Thanks.
Okay, so thank you, Naren, for this kind invitation. Good morning, everybody. I'm trying to, I will try to shorten my presentation just in some time. Yeah. So let's start with a simple case. 30. Yeah, thank you. So 37-year-old lady with presenting with a fifth episode of diplopia with facial nerve palsy and the coordination troubles associated with this lesion on the right lateral recess of the fourth ventricle. What's the diagnosis? Just raise your hand. Multiple cavernous malformations, familiar form. There is another small lesion here. What do you think? What about mixed vascular malformation? Just raise your hand. Okay. What about developmental venous anomaly? Or an AVM? Okay. Let's see that later on. Cavernous malformations are vascular tumors, mulberry-like, especially supratentorial, and there are the 15% of all vascular malformation. 40%, according to the newest series, are incidental. 25% are found in children, and in children, the infratentorial location is much more frequent than in adults. Histopathologically, the distinctive feature is the presence of abnormal vessel walls. No fragmented basal lamina, no vascular smooth muscle cells, no astrocytic end feet. There is essentially back-to-back vessels with no intervening parenchyma, even if the parenchyma is present in a very small percentage of cases. There is a thrombosis, calcification, ionization of the wall, and most importantly, all around the malformation, there are fibrosis, astrocytosis, and hemosiderin. And hemosiderin, when it goes into the neuropil, accounts for seizure. Immunohistochemically, there is a positivity for normal markers of endothelial cells. So there is no evidence that endothelial cells abnormalities are responsible for the thrombosis, which is due to a low flow inside the malformation. The alpha-actin is present just in the endothelium and subendothelial layer. So it's absent in the amorphous part of the wall because there are no vascular smooth muscle cells. And then there are a lot of markers of angiogenesis. Generally, let's say traditionally, these malformations are considered congenital. In this case, they can be sporadical, and sporadical they can be single or multiple. And generally, when they are multiple, they are associated with a DVA or familial. And familial forms are multiple and are due to the presence of one of those three germline autosomal dominant mutations with a variable pentron. But they can be also de novo and associated with irradiation, brain biopsy, CNS viral infection, and also been described associated with functioning pituitary adenomas and in pregnancy. But whether the mutation is inherited or acquired, the loss of expression of CM genes in the neurovascular unit lead to dilatation of major vessels, a defective endothelial association, a defective barrier function, and a dysfunctional sprouting. So, considering what I've said just before, the correct diagnosis is a mixed vascular malformation, because even if there are multiple lesions, the association with the DVA rules out the familiar form. Bleeding is a major issue. As you all know, cavernous malformation is associated with some evidence of occult or apparent hemorrhage. Patients with supratentorial cavernomas frequently recover from bleeding, but patients with infratentorial lesions generally have progressive recurrent bleeds that result in cumulative disability. And what is very important to stress is that perilesional bleeding is worse than intralesional bleeding. The 5 years risk of symptomatic bleeding has recently been quantified. An incidental hemispheric malformation has a 4% 5-year risk that doubles for incidental brainstem lesion. This risk goes up for hemispheric malformation with a prior history of bleeding or neuro deficit. But the highest risk is for brainstem lesions that have bled, that have been associated with focal neurological deficit. Interestingly, initial age, gender, size, or multiplicity are not associated with the bleeding risk. There is also a temporal clustering of bleeding. It means that there is a decline of the hemorrhage risk 2 years after bleeding, according to some others. There is also a probable correlation between the Zabramsky classification by MRI and the risk of hemorrhage. The highest risk of rebleeding is for the subacute hemorrhage that looks hyperintense in T1 and hypointense in T2, while the other hemorrhage, whether subacute, chronic, or even multiple punctuate microhemorrhage, have a much lower risk of hemorrhage. There are some factors that promote surgery. First of all, progressive neurological decline and also clinically significant hemorrhage. Some others wait a second clinical significant hemorrhage in eloquent cortex, but also young patient age, medical intractable seizures, and even patient risk adversity should be taken into account. But in general, surgery is proposed for lesions with repetitive or progressive symptoms, while prophylactic resection of asymptomatic lesions is not useful, is not indicated. Regarding epileptogenicity, which is probably associated with the ionic effects of the iron deposition with the hemosiderin, with the presence of the hemosiderin in the neuropil, the supratentorial malformation are associated with a prospective risk of epileptogenicity. Seizures can be partial with a localization-related semiology, can be complex in temporal location, frontobasal and paralimbic locations, and with a potential for generalization, and in case of multiple lesions, can be very difficult to attribute seizures, the origin of seizures, to a particular lesion. Seizures may become intractable and cause disability. Seizure outcome is better, the surgical outcome is better if the seizures are of recent onset. In case of chronic epilepsy may not respond just to lesionectomy, and sometimes frequently, the lesionectomy plus, which means the resection of hemosiderin-stained brain together with a mapped epileptogenic foci, is proposed in, obviously, in non-eloquent location. Seizure outcome is quite good. In a very early series, has been achieved a 97% of patients seizure-free at 1.5 years, and the same authors found, let's say, quite satisfactory outcome of just 3.2 permanent disability, even if I'm sure the most recent series now have even a better outcome concerning the neurological outcome. But for brainstem cavernous malformation, the situation is completely different. Brainstem cavernous malformation are approached at the pile or ependymal surface. It means that generally, when they are separated from the pile or ependymal surface by normal brain, a follow-up is proposed. Even if very experienced vascular surgeons propose surgery to accessible symptomatic lesions, even if they do not reach the pile or ependymal surface. Very important, always spare the DVA, the associated, which drains normal brain. For what concerns the neurological outcome for brainstem cavernomas, it is disappointing, at least for the larger series, and reaches in the immediate postoperative period 70% of mobility, with a percentage of gastrostomy and or tracheostomy of 10%. The permanent morbidity is lower, but still high, up to 37%, and mortality is not zero. There is also a percentage of hemorrhage recurrence up to 3.5%, which is generally due to incomplete resection. Stereotactic radiosurgery has been proposed in really prohibitive lesions, but the effect is no repetitive bleeding 2 or more years after the procedure, but it should not be used as a mainstay for the treatment of this malformation because of the delayed effect, because of the appearance after radiosurgery of de novo, been described de novo malformations, because of the appearance of severe edema that is responsible of a worsened clinical status. And also, recently, another drawback of the stereotactic radiosurgery has been described, the hypertrophic olivary degeneration, which is due to the interruption of the rubro-dento-olivary connection, and is associated with ataxia, dysarthria, myoclonus, palatal tremor, and other disabling symptoms. So, given the risk of growth and subclinical hemorrhage of these malformations, especially in children, follow-up is important. Clinical and radiological follow-up is very important, especially in familiar forms that are a dynamic disease. The evaluation of relatives at risk is also very important. It should be done with molecular genetic testing and obviously with brain and eventually spinal cord MRI. And in conclusion, cavernous malformation are increasingly detected incidentally, up to 40% of all cases. They are not a truly benign lesion. The indication for surgery should be tempered by the individual patient and lesion features, and the follow-up is necessary, especially in young patients which are not treated surgically at diagnosis for infratentorial location and familiar form. I'm finished. Now, if you have a question, yeah. Thank you.
Right on Juvian, and now he has another
Dominant.
lesion. Yes,
Silvia?
dominant, but he has now. So now he has a very small lesion,
27. Right.
and I don't know actually what to do.
What
I
to
was
do?
thinking of stereotactic.
The risk, as we've seen that, well, we can have an appreciation of the rebleeding risk, which is about 1 in 5 years. So maybe you should consider to reoperate before, because I mean I don't know exactly the location of the lesion,
It's,
but
the
if
opposite side, another of,
there are 2 lesions,
the first one is operated.
Yeah.
And now has
which
another
one has been operated? The one that bled.
Yes.
Right.
Now he has the opposite side, right here, another.
But the one that have been operated have been eradicated, have been taken
Yes,
out completely.
yes, I think.
Okay, right. Okay. Oh, no need to operate on the other one unless
Just for
it depends. It depends on a lot of things. I would not operate on it. I would follow it up. It's not you rule out a familiar form. Well, just rule out with anamnesis with a familiar. You know, if there are other cases in the family, 2 lesions. Is there any DVA associated? DVA associated,
I
developmental
no.
venous anomaly
No.
associated?
No.
Well, I would follow it up. Yeah.
Could I possibly ask? It was a fantastic talk.
Thank you.
I just wanted to find out, what is your regimen for following up these patients? How often do you follow them up?
1 MRI a year, generally. I mean, I obviously I accommodate. It depends. For example, for a 4-year-old, I would try to follow it up, maybe more closely, but generally no more than once a year. It depends on the location. Really depends on the location, on the age of the patient, whether it has been asymptomatic or not.
If the patient remains asymptomatic, what are you looking for on the eye scan? And what would trigger?
Enlargement.
And enlargement would trigger you to do something about
it. I mean, really, the method of putting an indication is not just on the MRI. You have to correlate the MRI with the symptoms, whether a patient is going to be put on anticoagulants or whether she's going to have a baby. A lot of things, a lot of factors. I cannot really say this patient with a supratentorial cavernoma, which is enlarging a bit, is going to be operated or not. It depends really on a lot of factors, or multiple factors. But the follow-up is important because you have to have a very precise idea of the eventual evolution. There are some forms that are really aggressive. Others, I mean, they don't really have any evolution, neither clinically or imaging.
Thank you.
Just going to go to, you can. I'm really grateful.
The next one, yeah.